Endoscopic tips for intragastric balloon use for obesity. What you need to know. Intragastric balloon is a minimally invasive treatment option for obesity and its related comorbidities. It functions as a space-occupying device within the stomach, inducing mechanical gastric distension. As a result, it generates a sustained sensation of satiety, leading to weight loss. On average, patients lose 6 to 16% of their total body weight in 6 to 12 months. Several balloons are available on the market, but only a few have gained approval. Highlighted here are the commercially available balloons and their efficacy in weight loss. Here are the indications and contraindications for intragastric balloon insertion. Primarily, it is indicated in patients with BMI more than or equal to 30 who have failed diet, lifestyle, and pharmacologic interventions for weight loss. It also serves as a bridging intervention before bariatric surgery and is indicated in patients at high risk or those who refuse surgery. In this video, we deconstruct the steps for the insertion and removal of an Orbera intragastric balloon, aiming to address a gap in the clear documentation of this technique. Additionally, we will discuss potential scenarios that may arise during the procedure as well as complications associated with an intragastric balloon. In inserting an intragastric balloon, we need a mixture of sterile saline and methylene blue connected to a flushing pump. The first step is to perform a diagnostic gastroscopy. This is crucial to assess the presence of any contraindications for insertion. If none are found, we can proceed with the balloon insertion. The procedure may be performed under general anesthesia or monitored anesthesia care depending on the patient's risk profile. First, advance the gastroscope at about 25 cm level from the incisors to open the upper esophageal sphincter. Lubricate the balloon with a water-soluble lubricant for easier insertion. As you slowly advance the balloon, pull the gastroscope while maintaining a clear endoscopic view. Once you see the tip of the balloon catheter, simultaneously advance the gastroscope side by side with the balloon until you reach the stomach. Adequately distend the stomach and position the gastroscope after the GE junction to get a global view. Connect the flushing system to the catheter, then start inflating by pressing on the pedal. We generally fill the balloon with 650 ml of fluid. When a leak is seen at the catheter balloon junction, fill the balloon as much as possible to allow for puncture and deflation. Then, remove it and place a new balloon. Once the water jet is empty and the balloon is completely inflated, slowly pull the catheter until it dislodges from the balloon and then completely pull it out. Lastly, inspect the stomach and confirm the balloon's position. Here is a case of a difficult balloon insertion in a patient with a short neck. Despite endoscopic guidance, the short neck restricted the maneuverability of the scope during insertion. In such cases, optimal patient positioning becomes crucial. Ensuring proper alignment and extension of the neck may facilitate passage of both the balloon and the gastroscope. The intragastric balloon extraction kit is composed of the needle catheter and the grasping forceps. In removing an intragastric balloon, it is important to consider the possibility of residual food particles. We advise the patient to follow a liquid diet for 3 days and 12 hours fasting before removal. It is recommended to safeguard the airway with general anesthesia and place the patient in left lateral position to allow fluid and balloon displacement to the fundus. Alternatively, a silicone overtube may be used. Once sedated, insert the gastroscope into the stomach until the balloon is visualized. Position the scope 2 cm away from the balloon and look for a safe and stable area to puncture. Puncture the balloon with the needle catheter. Withdraw the needle and push the catheter further in. Then, connect the catheter to the suction machine for continuous aspiration. It is crucial to be mindful of the needle and the catheter's location during deflation, as repuncturing may be very challenging and potentially unsuccessful. Continue deflating until the balloon achieves a thin, crisp, and folded shape, then grasp it with the forceps. Complete balloon deflation takes about 3 to 4 minutes using the suction machine, but may take longer when done manually with a syringe. Ensure that the balloon is completely empty and deflated. Using the extraction forceps, grab the balloon at one fold and pull it closer to the scope. If the balloon is situated in the fundus, it can be retrieved in the retroflex position. Secure the forceps, then gently pull the scope together with the balloon until completely extracted. Here are some scenarios which may be encountered during balloon removal. Do not attempt to extract the balloon if it's partially deflated. This may cause inadvertent injury of the esophageal mucosa, commonly at the GE junction or cardia. Therefore, it is crucial to completely empty the balloon before removal. In case of incomplete deflation after aspiration, multiple needle punctures at different sites may be done to allow drainage from multiple areas. Avoid poking too far from the balloon, as this may lead to sliding of the needle. This may cause inadvertent injury to the gastric mucosa or even perforation. Additionally, swift poking may also lead to sliding of the needle and cause inadvertent injury. If a needle catheter is ineffective or not available, endoscopic scissors can be used to create larger holes or slits for drainage. You may also enter the slit and directly suction the fluid. In situations where the balloon is degraded and fragile, grasping multiple folds will provide a better grip, facilitating its retrieval. In some cases, there may be food residue seen in the stomach that may pose a risk of pulmonary aspiration. Emphasizing the importance of adequate fasting and protecting the airway during the removal can minimize this risk. Now here are some complications associated with intragastric balloons and predictors of early removal. Nausea and vomiting can occur in 90% of patients. If these symptoms do not improve after 48 hours, they may indicate a patient's intolerance to the balloon. Conservative management with medications such as PPIs and antiemetics may be prescribed. However, if symptoms persist, balloon intolerance or gastric outlet obstruction should be considered. In these cases, patients may require balloon removal. Antiemetics or prokinetics may then be prescribed for as needed use. As the balloon is a foreign object, its presence can be associated with irritation of the stomach wall, potentially leading to formation of ulcers and, in rare cases, perforation. Seldomly, balloon hyperinflation due to fungal colonization occurs. This can result in degradation of the balloon, making it rigid and friable. In such instances, removal using forceps will be technically challenging. Instead, an endoscopic snare can be used for extraction. In summary, the safest method to place an intragastric balloon is under endoscopic guidance with a protected airway. Patients should be maintained on PPIs throughout the duration of the balloon implantation. Removal of the balloon is preferably done under general anesthesia to mitigate the risk of food aspiration. Familiarity with potential scenarios enables the endoscopist to respond promptly and effectively, thus minimizing the impact of complications.